Good morning, everybody. Thanks. Sorry that I wasn't here during the introduction. I'd like it to be a little interactive. I was going to tell Layla to introduce me and say it's going to be an interactive session. Like, I'm going to ask you some questions. Why don't you show me what you know or don't know, kind of thing. And a lot of them will be extra credit questions, where I won't deduct from your final score. You know, some of them I'll have to deduct. You know what I mean? Anyway, I'm going to be talking about the importance of having a dressing that adheres. These are my disclosures. I do speaking for the following companies, so I'm biased. Got to declare that. Let's see. Is this thing working or not working? All right, so what's the goal in all this? The way I see it, we want to standardize practice at the highest level because we work on human beings. So you hear this all the time. It's like systems engineering. We're not talking medicine or respiratory care anymore. We're talking about this other stuff. And like, it's important for sure. You know what I mean? But like, what do you get? What's the big deal on standardizing practice? What do you get out of it? You know, a lot of times you'll hear these things and you don't think about them because you hear them so much, you know, but they tell us about, like, what do you get out of standardizing practice? It can eliminate unnecessary variation. What do you think unnecessary variation does to your outcomes? Nothing good, right? Somehow I can't get this thing to work. All right, so the Never event. In 2001, oh boy. Ken Kaiser, who was the chief of the CEO of the National Quality Forum, came up with the term never event. And never events in those days were leaving surgical instruments behind, operating on the wrong limb. That's a never event. But in 2008, CMS adopted never event and made it for CLABSI. So CLABSI is designated as a never event, right? So meaning that hospitals are not to be reimbursed for the cost of their treatment. So it sounds to me like they never want to pay for this thing. You know what I mean? It's certainly an event. I mean, like, if there's never an event, we all have too much experience with the never event. You know what I mean? So in the year 2023, experts in vascular access, I mean that. What's the number? How many of these things were there in 2023? Anybody want to venture a guess? That's an extra credit. So basically, there was an estimate of 250,000. Now, we're all reasonable people. You can call it a never event, then it occurs 250,000 times. So you can call it what you want, right? But it's not, right? So does that, you know, and this is the reference if anybody wanted to, whatever, get it, right? But suppose the RN or infection preventionist finds a disrupted dressing, right? What are you supposed to do? Thank you very much, yeah. I mean, the infusion therapy standards are pretty clear on this. They don't talk much about what happens to the patient when a dressing is disrupted. But there are some studies, you know, and we'll get into a little bit of that, you know what I mean? But I called Lisa Gorski, the lead author on this last winter, and she called me back in the discussion. She said, Jack, yeah, we know you got to change the dressing, but you got to ask, why is it disrupted? You know what I mean? And one of the things that you got to keep asking why if you want to get down to the root cause of these things. No, yeah, change the dressing. The next shift can change the dressing. The next shift can change it twice. It doesn't solve the problem. You got to ask, why is it disrupted? All right, so disrupted dressing. Clearly, it's a deviation from optimal care, like in the operating room. You know, if there's a break in aseptic technique, everybody puts their hand up and the tech puts sterile towels down, you know, and you go about your business. Rarely do you change the full drape, but I've seen that in my career, you know, and exposes the patient to the toxic environment of the ICU. Like, even if a dressing is disrupted for 10 minutes, it might be over for that patient. You know, sure, we change the dressing, or better, we tape it down. Anybody ever see a dressing taped down? You know what I mean? And it's waste. A disrupted dressing is waste. And what do I mean by waste? Nursing time. Nurses are not supposed to be wasting their time changing dressings unnecessarily. And the thing about waste is you're spending resources and you don't get anything in return. It's just waste, you know? So the problem as I see it is that central venous access devices in the United States of America, big, great country, wealthy, you know, we're all, you know, doing our things. Like, we're doing this suboptimally. And you could put another word in there for suboptimally. I know Vince is thinking through the list. You know what I mean? Yeah, suboptimally, like, right? Then the second thing is the dressings aren't staying on for 7 days. And the third part is we're seeing 250,000 CLABSIs. Like, are these things related? You know what I mean? Like, it's one thing if you get a CLABSI and you did everything right. It's another thing is like you made a mess and a patient got a CLABSI. I mean, that's somebody's relative, somebody's loved one. You know, you got to take these things a little more seriously, right? So according to me, the state of acute vascular access in the United States is deplorable. And to me, this is what incipient CLABSI looks like. In other words, I don't need a positive blood culture to tell you that this is what it looks like before you get the positive blood culture. You know what I mean? It looks like a mess. As my son calls this, the mess on the neck, right? And if you found something like this, suppose like we were rounding, and we found the guy in ICU bed 3 had something like this, where do you go with it? Is there anybody's door that you can knock on and say, hey, doc, bed 3, it just looks like a mess, you know what I mean? You can't leave it, and there's nobody to bring it to. So we're kind of like, you know, stuck with it. Sure, do it right the first time, you know? But basically, somebody has to be in charge of vascular access. There's been a lot of advances in the field. If nobody's in charge of vascular access, you're not gonna move ahead, right? So there are 3 papers that I want to discuss a little bit, and this is Timson's paper. This is Annette Richardson talking about how long the dressings dwell, and this is Christy Gaskell talking about what happens if we glue the dressings down, right? It's like, do we need a paper? Do we need a paper to tell you this isn't good for the patient? Another thing is like, hey, I went to medical school. You see that green line on the adhesive on the hair behind the ear? What's that doing for the patient? You know what I mean? Like, this is like, people are doing things. The nurse is having to do things so she can get out of the room and go do her next thing. Like, so let's throw a piece of tape on the hair, right? But do we need a paper to tell us this isn't good? No, right? But you ever try to convince a doctor without a paper? Show me the paper. Show me the paper. All right. This is the paper. This is Jean-Francois Timsit, the famous French intensivist, talking about dressing disruption as a major risk factor for catheter-related infection, right? And Timsit found that 67% of the dressing changes were unscheduled. How does that number sound to you? Yeah, all that. And he found if the dressing was disrupted, the risk of infection or colonization went up by a factor of 3. If the terminal dressing was disrupted, went up by a factor of 12, right? And Timsit found that subclavian, in quotes, access protected from disruption, right? We'll get into that a lot more, right? So the first paper showed dressing disruption is bad for the patient. We didn't need that paper. We live it, right? The second paper is how long are these dressings staying on, right? So how long is a dressing supposed to last? 7 days. Thank you, right? I mean, Timsit found that they're, anyway. But how long are the dressings lasting in your institution? And let me tell you this, unless you're doing a research protocol, you're not going to know the answer to this question. It's not easy to determine. It's easier than a lot of things, but, nobody knows this, right? So anyway, Richardson did a study in the UK on these 4 dressings, and we're familiar with all of them, right? And so the dressing is supposed to be on for 7 days. What she found was the best one stayed on for less than 3 days, and the other 3 were on for less than 48 hours. People, this is a smoking gun. If we don't correct this, what are we doing? Like, how many papers come out with CLABSI reduction strategies? And I'm going, oh no, another CLABSI reduction, how about we put the line in so that the dressing stays intact, huh? That's a little crazy, So how can we improve duration, right? All right. So here's a patient, right? And, every nurse in the solar system would rather care for this dressing, you know what I mean? And let's see, what I have to say is, what antimicrobial products or techniques do you see out there dressing? What's preventing an infection there? Biopatch, it's a reflex. Biopatch, it's an antimicrobial catheter. It's got sutureless securement. It's laying flat. The dressing, I used to say, does that look like it's preventing an infection? But I've changed that. Does it look like it'll stay on for 7 days? Once it stays on for 7 days, I did my job. You see this other one, which my son affectionately calls the mess on the neck? Got the same antimicrobial products. It's got a biopatch, it's got a sutureless secure, it's got an antimicrobial catheter. What's the difference between the two?
All those products are being used in the
It's not put in properly. It doesn't, like, in order, I don't care what product you get, you got to put the catheter in properly. It's not put in properly. And like, you have to learn this. If we're going to use the jugular vein, we want it to look like this. All of your products are going to work better if the line is inserted properly. Jack LeDun, MD, 2012, right? So that's great. But how can we improve duration? How can we improve it, right? So this is Christy Gaskell. While it's clear that a clean, dry, and intact dressing is critical in the prevention of CLABSI, there's a lack of strategies to achieve this. Shelley DeVries said the same thing, that there's little published to tell us how to do this. How to get the dressing to stay on for 7 days. And that's kind of my message, right? All right. The problem is suboptimal insertion. Vince, give me a different word for suboptimal during this. Not this fall, but think about it for a different word. Crummy insertion, that's leading to dressings that aren't staying intact and 250,000 CLABSIs, right? So what's the solution to this? Preventing a dressing disruption is the solution to this. Well, how do you do that, right? Number one, you have to insert the catheter properly. There's no way around this, right? Number 2, 3, 4, and 5 is the same thing. Like, until we put the catheter in properly and get the dressing to stay on, almost everything else, sure, have a strategy to get them out. Have all your different strategies. We got to do this, right? Then after that, the exit site is crucial. And I got to explain. A lot of things we do are important. The washing your hands, draping the patient, that bundle thing, it's important. It's temporary. The exit site is permanent. The exit site is crucial, and it's permanent for life. Like, whatever, it's going to have a bearing on that line. Like if you didn't wash your hands and the patient developed an infection on day 10, it has nothing to do with whether you washed your hands or not. But the exit site is going to have a factor throughout the life of the line, right? And I want to have a dressing adhesive. I want that dressing to stay on for 7 days, right? So the infusion therapy standards, they're the ones that deal with this, right? Evaluate the beneficial use of a gum mastic liquid adhesive when enhanced adhesive adherence is needed. Now, that's a mouthful. But what Dr. LeDun says, you just want the dressing to stay on. I don't care about that other stuff. I want my dressing to stay on. I want to put the catheter in properly and then glue it down. All right, gum mastic. What is gum mastic? It's a cool product that drips from the bark of a tree in Greece. Come on. How do you not use something like that?
And it's very sticky. When it dries, it helps to so I'm just going to trace this, just like this. Well, this.
I mean, Matt Gibson uses it. Come on, what can you say? You know what I mean? All right, paper number 1, Timsey. Dressing disruption was bad. Paper number 2, Richardson. How long is the dressing staying on? Not for a long period. This is Gaskell's paper that came out recently, right? And their initiative supports the evidence that a clean, dry, intact dressing can be an indicator of patient's risk for CLABSI, right? So she found in her institution that 64% of the dressings were compromised by lifting and peeling, 82% bleeding. I said, Christy, this is an issue. Like, mine was 2% bleeding. Like, why? So I'm thinking beyond today's discussion, what did I do to get a low bleeding rate? I didn't cut the skin, and I used micropuncture equipment. Basically, I have to look at what other things I did there. And she found, like Richardson's paper, the average dwell time in her protocol was 2.7 days. They're supposed to be 7. They're not on for 3. You got to fix this, right? So they introduced gum mastic and hemostasis with their 82% bleeding. Luckily, they introduced some hemostasis, right? And they found that the dressing integrity was markedly improved. And this is at the smoking gun. The life of the dressing went from the 2.7 days to 6.5 days. It's supposed to be on 7, we're up to 6.5 by the introduction of the gum mastic and hemostasis, right? So to me, this is closing the loop. We didn't have this study before. We had Tim's study, we had Richardson's study, but we didn't have a study that shows if you use the gum mastic, do the dressing stay on? And now we do have that. And there was no Marcy with this, right? All right. So the authors, Gastel and DeVries, are saying there's not much published on how to get the dressings to stay on, like what we're doing. The way I deal with this is I call the life cycle the central venous catheter with the goal of standardizing what we're doing in each phase of the life cycle, right? And another way to look at this is the chain of CLABSI prevention, and the chain is only as strong as its links. All right, talking about assessment briefly. So this is the MAGIC paper. MAGIC is an assessment paper, 2015. I'm one of the lesser authors on the MAGIC paper, and this is an assessment paper. This is not an insertion paper, certainly controversial paper, right? So basically, there are good reasons to put in one of these devices, and there are bad reasons. Good reasons include hemodynamic monitoring and TPN. You cannot do hemodialysis without central venous catheter. Peripherally incompatible meds. This picture was sent to me by the immortal Joe Bunch in Chicago, and they gave this patient a high dose of bicarb and levofed through a peripheral IV and like the anticubital. The patient didn't get CLABSI. He got an amputation because we gave him the wrong medication through the wrong device. Go ahead, there are papers that come out and tell you can do this, right? And certainly if there's, multiple access needed in a critically ill patient. See, this patient has 3 atypical IVs, and Matt Gibson was getting called to put in the 4th peripheral. Hey, give him a central line. Give him anybody that we give anything through these things, you know what I mean? Like, so that's where to me the literature gets screwed. Like, not every peripheral IV is the same, and these are, anyway. All right, but there are bad reasons to put in a central venous catheter, right? And the worst reasons probably general access. Hey, Dr. Ladon, I couldn't get a peripheral IV. Can you come put a central line? No. But I did that for decades before we developed the nursing vascular access team. Now they solved the problem with the ultrasound guidance, right? I mean, like I did that forever, right? Another one of my favorites is just in case. Listen, my favorite thing in the world is that IV line in ICU, the peripheral, it's not working, but we're going to leave it just in case, in case we don't have a bacteremia, maybe we can give them a back. Well, what's the just in case for a non-functioning line, right? And if the patient is a difficult IV access, I heard you don't have that in Arizona, that we want to go to a ultrasound-guided peripheral IV or a midline before you get into the central line. This simple scheme is going to cover 97% of your patients. Basically, the message for the assessment phase is have a good reason to put in a central line. It's not hard. It's not hard to have a good reason, and we got to standardize it. Moving on from the assessment phase, we come to stage 2, pre-insertion. What is the insertion line. The beauty of stage 2 is it's standardized, evidence-based around the world. What you're doing in Phoenix is what I'm doing in Baltimore, what they're doing in Sydney, Australia. We're doing the same evidence-based practice at the highest level. That's got to be the model for the other phases of this thing, right? So this was originally described by the CDC and the Institute for Healthcare Improvement and validated by the Keystone Report, Dr. Peter Pronovost, Johns Hopkins Anesthesia, the lead author, right? This phase, the pre-insertion, lasts from the time we do our hand hygiene until we drape the patient. It's standardized around the world, right? So we all know this thing consists of 5 things. Hand hygiene, flexing your skin prep, maximum barrier precautions, daily review for necessity, and avoid the femoral site, right? And it takes around, I'll get into that in a second. So I was asked to rewrite the insertion bundle. And what I did was I removed daily review of necessity. For this reason, it has nothing to do with the way we insert the lines. It's clearly a care and maintenance practice. But when they came out with that bundle, they didn't know where insertion stopped and care and maintenance started. But it has nothing to do. I mean, it's out of my insertion bundle. Nope, sorry, out. And the other change I made was, instead of avoiding the femoral, it's avoiding the groin. See, like calling this the femoral vein, it's not enough. Calling an internal jugular, it's not enough information, right? The femoral vein goes from the groin to the knee. And it's not the same by the knee. It's not the same in the lower thigh or the middle thigh. You want to get it out of the groin. My point on this is, phase 2, evidence-based, standardized around the world. It takes 90 seconds to do it. And the paper by Pronovost was credited with a 5-fold decrease in the collapse rate. You're telling me if you do this 90 seconds right, you're going to get a 5-fold decrease? That was 2006, right? It was dubious then. It's silly today. There's a lot more to vascular access than these 90 seconds. All right, during today's talk, we're going to discuss 5 procedures, right? The first one we're talking about now is the mid-femoral, as alluded to in that bundle where we change it. This is Matt Ostroff's paper from New Jersey, and this is how you do a mid-thigh femoral. So I'm about 14 centimeters below the groin crease. The groin is the problem. Micropuncture equipment always. We don't incise the skin. The skin is the natural barrier to infection. We try not to damage it with sutures,
Cut it.
or incisions as much as possible.
Or just found that. I just did it come out. Yeah.
Do you think that procedure would be beneficial to the patient in your institution? Then you have to learn how to do it. It can't just be, oh, hey, wow, this guy showed a great procedure. We're not going to do it. Because that doesn't really make that much sense, right? All right. Moving on from stage 2, evidence-based around the world, we come to phase 3, the actual insertion of the device. Now, if you're an OCD note taker, be my guest. We will send you the PDF of this video. We'll send you whatever you want. If you want to take notes, be my guest. Don't take your cameras. We'll send you the slides, right? All right. Moving on to phase 3, the actual insertion of the device. My motto for this is insert the catheters properly. Now, it's ridiculous in 2025 that you have to say that, but you do, right? This phase lasts from the time you drape the patient until you put on that dressing. When I put in a line and put on that dressing in intensive care unit, by definition, the patient is now in care and maintenance. That's when insertion stops and care and maintenance begins, right? So in this phase, you want to figure out what are the best practices, but then do the best practices. We don't want to figure out like this is better, this is better, this is better. We're not going to do it because you don't really get ahead that way, right? All right, so basically there are 5 phases to this thing in the Ladun framework, right? These 4 account for 1%, and the dressing, care, and maintenance phase accounts for 99% of life. So if you may impact infection, would you deal with the little orange sliver or the big blue pie? The action's clearly in the big blue pie, but they're related. The way the nurse cares for this thing depends on the way we insert them. It is not talked about nearly enough, according to me, right? But what happens after you insert one of these lines, right? It's given to an RN to use and to manage. CVCs are nursing tools, right? So before we start, nurse, I think what this catheter is, that or this chest. Where do you prefer to care for it? The catheter, is it so the chest or is it some of that?
Going to the chest.
Why?
Because it's easier usually the dressing a line black.
Thank you. What I like about that short video is the inserter asked the nurse, recognizing like that's your partner, that's your teammate, and the fact that she has it for 99% of the life, I think they're the ones that should be judging like if a line is put in properly or not the guy with the fancy degree. All right, so I talk about proper insertion. Just so we're on the same page, what am I talking about? Number 1, minimal attempts, hopefully 1. Number 2, we want the tip close to the cavo-atrial junction. Let me go on the record. There's a counter. Are you guys believe the tip should be down near the cavo-atrial junction? There's a counter narrative from anesthesia, critical care, and the emergency department. They show their papers and they've got studies that, but anyway, I'm not going to go down every tangent that I come to, but there's a counter narrative on close to the cavo-atrial junction. You want a proper exit site and not the mandible or the ear. You want a proper exit site. You want to use sutureless securement, antimicrobial protection, and you want the dressing to stay on set for 7 days. Once I've done that, I've done my job. And now, if you will call me, I'll come back and see the patient, but I don't have much to offer as long as I've done that, right? So where are we? Phase 3, the actual insertion of the device. I say that there are 16 decisions, they're choices, and these are my recommendations. And these are the 16 things. And we're not going to go through all of them today, but we'll go through some of them for sure, right? This is the paper I'm reading from the Gavaselt. Tim, well, no, Tim's not Gavaselt, he's Wacova. But this talks about a lot of the stuff that I'm talking about. It's been a compilation, over the years, that kind of thing. So I was by 16 recommendation. Recommendation number 1 is ultrasound guidance. Always. Just, Amy, I think you've heard me say that once or twice, right? All right. So, interact. What is your go-to site? Say intensive care. Where do you put the line when you get called?
Yes.
IJ. Okay.
No, cause ain't nothing. You're the one from break.
Those of you who haven't been doing your radical neck dissections lately, that's the internal jugular vein, So what's the problem with the jugular vein? It's the most popular site, in the country, right? In the world. There are too many ways to do this procedure poorly. It's not standardized. It's not done in standardized fashion like they're telling us. If you're doing it different than I'm doing it, it's telling us we're not standardized, right? So you could put it high, you could put it in the middle of the neck, and you could put it low in the neck, right? So what do we want the IJs to look like? Do we want it to look like that? Or do we want it to look like that? Tell me. This is the interactivity. Which one do you want?
That in mind.
Thank you. All right. So do you want it to look like this? Or do you want it to look like this?
Yeah.
Okay. So, people, what are the steps to achieve it? What are the things we have to do to achieve this so it doesn't look like the other ones that we showed, right? So, vascular access experts. You can have it high, middle, or low. Your choice today. We're here in, where are we? Scottsdale? Or Phoenix? We're in Phoenix. There's a dividing line someplace. All right. Tell me. We want it low in the neck, right? Anything else is not standardized at the highest level. It's not like we want it low in the neck sometimes. We want it low in the neck unless there's some extenuating circumstance, right? So, Ledun principle number 1 for the internal jugular vein is low in the neck, and I consider this to be mandatory. Now, the catheter in the dressing, I'm not going to get into this too much, but the catheter can exit from the dressing. The catheter has to exit from the dressing. You can't coil it up like a snake underneath the dressing. Maybe Tiger can do that. But you can exit north, south, east, or west, right? Which configuration standardizes practice at the highest level? South. Exactly. So we have it low in the neck and we direct it south. Again, not once in a while, not when you're on call, but you're not on call, like you have to do it this way, right? Anything else is not standardized at the highest level. Another thing is the doctors bring up, it'll kink. I'm waiting for my first kink. You know what I mean? And if I got a kink, I still wouldn't change my practice, I'm sure, right? IJ principle number 1, low in the neck. IJ vein principle number 2, rotated down onto the chest. We'll get into that a little bit, right? So this is what I'm talking about.
All this thing down toward the chest, not near the ear. Okay, I do not want this dressing up near the middle of the neck. I want it down toward the chest, where it's down. With the slit facing the catheter, I'm going to offset it on just a small amount, maybe about 10 degrees. But the catheter, buckle in, and the skin prep. Okay, so then take up the wrist. Right. Second one.
All right, so you see this one here. So like Lisa Gorski, Jack Ledun. Why is it disrupted? The catheter exits from the top of the dressing. Then gravity grabs it and pulls it toward the floor. In the patient I just showed, the tails are coming out the bottom of the dressing. Gravity's working with it. It has to be done this way if you think an intact dressing is important to the patient. And probably having an intact having an intact dressing for 7 days is the most important thing I can do for that patient to prevent infection. I do the other things properly. But if I get my dressing to stay on for 7 days, then I've done my job, right? 55 years ago, an English physician named Ian English wrote up the technique for the internal jugular vein access, right? But in 2025, we don't have to do it his way. If we practice anesthesia like it was 1969, we'd be out of date as well, right? So a year after English wrote his paper, Jernigan from Kentucky wrote his paper, like how he does it, right? So he's coming like from the side of the bed, not the head of the bed, right? And basically, when I look at mine, it looks like the way we do it. You know, we come from the side of the bed, low in the neck, and we're going to rotate it down. But look what they did, Jernigan did with the catheter after he got it in. He didn't realize that you could do this. You could rotate it downwards. So rotate, you know, that's what we used to do with kids, have stuff draped across their forehead and stuff like that, right? So in 1970, I'd give him a pass, but I wouldn't give him a pass today for doing that, right? So basically, here's a paper from a famous medical school in New York City, right? Talking basically about what I'm talking about, quality assurance in CLABSI. Are there exceptions to never? I guess there are exceptions, right? But this paper showed that their analysis revealed that CLABSIs were most frequently associated with internal jugular access. Their own data, right? But now they're going to tell you why they chose to use it. So their data showed the jugular vein had the worst infection record. Now they're going to tell you why they use it. Like, for me, I would tell you why I did something else. If that my data showed that's where you got the most infections from, now I'm going to explain why I went to another site, right? So these are their reasons at the famous medical school in Manhattan, right next to the park. Reason number one for choosing jugular vein, their patients are sick. And there's no doubt, during the pandemic, they were on the nightly news every night at 6 o'clock, and their patients look dreadfully ill. They're no sicker than your patients. You know what I mean? And like, for me, I don't give sick patients an increased risk of infection. I think that just by being sick, they have enough risk of infection, right? I don't do that. Their second reason, we're training residents. I always say, if anybody has a weapon, I want you to end my life right now. When I'm teaching a resident to do this procedure, they learn to do it my way. I don't dumb it down to them. They have to learn to do this thing. This insults me. This gets me. I wish I could have a debate with the authors of that paper if this is their reason. I'm sorry. No, this is not how you do things, right? And the third thing for choosing the IJ is this employee in quotes, is it easy? Now, it's the axillary vein, and they're right. It's not easy. Until you learn how to do it, then it becomes pretty easy. You know what I mean? Yeah, nothing's easy until you learn how to do it, So, 5 procedures. We talked about the mid-thigh. We're going to talk about the internal jugular vein, right? This is their paper. And so I was at the institution, right? Jonah Paris brought me in there. Jonah's, you don't want to go against Jonah, you know what I mean? But Jonah in this institution didn't, see eye to eye, right? So I'm on my way in to view a procedure, and I tell them, by the way, I've got my video camera with me. I know you're not going to let me use it. And they're, yeah, sure, go ahead, do your, so now, big famous institution, some guy from the outside with an unstable personality in a video camera. Like, what could go wrong here? You know what I mean? So I labeled this video I'm going to show you is how not to do a jugular vein insertion, right? What I like about this video is the people sound like me. You got this cool Brooklyn accent, right? Everything in the titles I put there, I don't agree with. They start at the head of the bed. Where do you think the dressing is going to be when the inserter starts at the head of the bed? Huh? They did use ultrasound. Otherwise, it's in English in London in 1969, right? Middle of the neck. No, you have to use micropuncture equipment. We want micropuncture equipment.
Oh, I gotta say that.
I thought he was going to dilate without incising the skin, and it may have warmed my heart, but he grabbed the scalpel, and he made a nice little nick. So I thought he was going to dilate. All right. Makes a nice little nick.
He's coming, don't move. Cut. Good. Wait.
Pay attention to the ear.
5 times.
I don't want you to see the ear during these procedures. Let's suture it down nice and tight, really hamper the nurse's ability to cleanse it. Like, let's get the ear out of the way. The ear's in the way of my dressing. Yeah, the dressing's not supposed to be anywhere near the ear. I don't use heparin.
That's nice work.
So that's why, look, I was telling the fellow nice work. I was being polite, but as we discussed earlier, standardize at the highest levels. Low in the neck, rotate it down. That ain't it. Right? Then we're going to give the guy TPN. You know what I mean? Like, come on. But there's something wrong in this stuff, right? So what can you infer about the inserter? What can you infer about the inserter? He did this or the previous one. He needs remediation, right? What about the person that trained him? Shouldn't be training people. You know what I mean? But like, all right. And suppose the ICU director finds this, comes in the morning, right, and finds this. What should he do? You think there's any literature that says you should fix it? Huh? You think they should fix it? Do you think, if you find this, you think it should be fixed or what? Right? Show me the paper. You know what I mean? Like, it's hard to find stuff like this. You know what I mean? So I'm at that institution for 2 months. I'm trying to show them like the Lord method, how we do things. You know what I mean? The able way. And I was there for about 6 weeks, and we're rounding in the ICU with decision making. And that's the key. As you know, you got to get the people. So I had the chief medical officer, I had the chief of the ICU, and a trail of residents and stuff like this, right? And we found that dressing on the patient's earlobe, right? And 2 days, and I pitched a fit. Like, no, I was being nice. I didn't say what, the balloon in my head wanted me to say, And I'm telling them, this is, you don't put it in so the dressing's on the earlobe, right? So 2 days later, that dressing was still in play. I'm thinking, what am I doing here, So the chief of the ICU was walking by. I was in the coffee shop with my son, and the chief of the ICU was walking by. This is a reenactment.
Hey, Dr. Blake. Yes. Another patient we saw 2 days ago with the central line dressing attached to the patient's earlobe. Yes. That line is still in place. It kind of indicates to me that the leadership of the ICU is willing to tolerate a poor quality of care.
And by the leadership of the ICU, do you mean me?
Now, I have to say, that didn't work out for me so well, and I have to find a different way rather than the frontal assault telling him it's tolerating and poor quality of care, you know what I mean? But that's the message. If somebody sees that, it wasn't on him. He didn't do it. He came in Monday morning and he found it. When he went home Monday afternoon and didn't do anything about it, now it is on him, right? And basically, you can't fix the problem if nobody accepts responsibility. Somebody's got to be in charge of this stuff. They don't know. They don't know the earlobe dressing's wrong. Somebody's got to point it out and show them how to do it differently, right? So, it's going to be interactive here. Why do MDs do this? So we're going to ask why. We're going to find out. I don't think we can solve this problem. Amy hasn't solved it. Jack hasn't solved it. Together we haven't solved it. It may not be solvable. It may not. But until we figure out why they're doing it, we're not solving it. So why? Anybody? Extra? This is one of those extra credit. I'm not going to deduct. Yeah. Go ahead. Why do MDs do this?
They don't better.
They don't know better. They were trained.
Got to start at the academic level.
But, all right, but why were they trained this thing? Keep asking why. You keep asking why. Why were they trained this?
That practice.
Low risk of pneumothorax. We said that. Why? My man. Yes. Low risk of pneumothorax. That's why they do this, right? So what is their guiding philosophy? And this is something, my guiding philosophy is standardize and practice at the highest level because we work on human being. I worked it out. I do it that's what I want to do. But if your guiding philosophy is we have to avoid pneumothorax at all costs, then you'll do something that may not be in the patient's best interest, but it may help you avoid pneumothorax. So what do they do? So if that's their guiding principle to avoid pneumothorax, what's the effect? What do they do clinically or not do because of that? So they utilize the internal jugular vein exclusively, thinking that that's going to be a lower chance of pneumothorax, right? And they won't go low in the neck. And sometimes they'll tell you, oh no, we don't go low in the neck with pneumothorax. Other times it's subliminal why they don't do it. But if if their guiding philosophy is, we're going to use, to avoid pneumothorax, they're only going to use the jugular vein, and they're not going to go low in the neck. And I see this all the time. I mean, it's at the observation phase, right? So basically, we've discussed earlier, we want to go low in the neck, and we'll get into like why we do that kind of thing. But if you put the dressing up by the mandible, right, you are going to have a lower risk of pneumothorax. There's no doubt about it. And like, it's a passive technique to avoid pneumothorax. And passive techniques generally good, like passive income. I love passive income. Like I did the work and each year I get a check for it. Yeah, hey, let's do that. So it is a passive strategy. Like the further you go away from the lung, probably the lower risk of pneumothorax. You can still get a pneumothorax, don't get me wrong. But you're right, the chances are improved, right? But what is the drawback of a high insertion? Crummy dressing, collapsing. I mean, so they're kept short. Sure, you're not getting a pneumothorax, right? So high insertion leads to a disrupted dressing, like the neck moves around like too much kind of stuff, right? So basically, when you leave here today, that guy was saying a lot of stuff. What was he, like, to boil it down, a dressing by the ear is bad, and a dressing on the chest is good. So if you remember that, okay, we'll have had a successful meeting here, right? What can we do to prevent pneumothorax and maintain an intact dressing? It's like those guys that are putting it by the ear, you could say right now, they don't care about an intact dressing because they're not going to be. But what can we do to prevent pneumothorax but maintain an intact dressing? Learn to follow the needle through the tissue. And that's an active measure, right? And you guys didn't think of that, but you do it every day. You can follow that needle through the tissue. It doesn't matter how close or not you are to the lung, right? You want to follow your needle through, and that'll allow us to have a low insertion, rotate it down, so we'll avoid pneumothorax, and we'll have a proper dressing. So that's the key there, that until they get this point, we're not going to get very far, I don't believe, right? But following the needle is a technical solution to the problem. Like there's no technical solution to CLABSI. Like it's not biopatch, it's not this, it's not that, it's the process. You know what I mean? Like the nursing bed's outlined 25 times a day. Like there's no technical solution really to avoiding CLABSI, but there is a technical solution to avoiding pneumothorax, and there's a technical solution. So like, this is my observation, that MDs are definitely afraid of pneumothorax. I mean, Mom, there's a monster under my bed fear. I'm not like, not a cerebral thing like, hey, maybe pneumothorax. Like, they're definitely afraid of this thing, right? And I want you to, so I've been thinking about this. Like, I came up in surgery doing blind sticks, and basically surgery did blind subclavians, and medicine did jugular vein, generally speaking, right? What happens if your ICU director, say the guy that I just had that conversation with, is teaching you to do an IJ high in the neck because he's scared of pneumothorax, right? You're doomed to practice the way you're trained unless something comes along that you have to learn. In other words, I had to learn laparoscopic surgery after I trained. There was a shift, I had to do it, right? Like, what happens to the guy that got trained under fear of pneumothorax? He goes on and he goes into critical care. He becomes a fellow. He becomes the chief of critical care. He trains the next generation to be scared of pneumothorax. We're 50 years into this. You know, like how they say you can't change the culture of an institution, Keegan? You've heard this, and it's true. It's very difficult. This is the culture of the institution. This is 50 years. This is like 10 generations of physicians deep. And they say this guy goes and becomes the chief medical officer, and he hires the critical care director. Nobody's training, and they're all scared of pneumothorax, and they don't see the relation that it's increasing the risk of CLABSI, right? So why don't MDs use the ultrasound guided axillary vein, what they call subclavian, right? Fear of what? Pneumothorax, as we've talked. Is the fear of pneumothorax rational? So let me compare pneumothorax to CLABSI, right? So basically, we're going to look at these things: morbidity, mortality, extend the length of stay, cost, prevention of the scarlet letter. Pneumothorax, the morbidity is minimal, right? But for CLABSI, it's extreme. Lumbar abscess, hip prosthesis infections. We don't even, because of the mortality issue, we don't even discuss the morbidity of CLABSI, right? Mortality. The mortality for iatrogenic pneumothorax caused in the hospital should approximate zero. I trained in the New York City hospitals. Once a year, every year, like clockwork, there was a tragedy because the surgical resident did put in the chest tube. Right. But that's one, that's one case. You know what the mortality for CLABSI is?
It's 10 bucks.
12 to 25% in all the big studies. That's the number that you're going to find. So like, they're scared of the wrong thing, right? Extend the length of stay. If you get a pneumothorax, some of the papers I read extends the length of stay about 4 days, and CLABSI is about 12 days. Cost, pneumothorax is expensive. You know what I mean? And CLABSI is very expensive. 45, I've seen it up to $120,000, right? And then prevention. The prevention of pneumothorax is straightforward, right? If you can do this, if you can follow your needle through the tissue, it's a technical solution. You won't get pneumothorax, right? But the prevention of CLABSI is complex. The nurse invades that line 25 times a day. Like, there's no technical solution to it, right? And then the scarlet letter. If I cause a pneumothorax in Baltimore, you'll know it. The word will be out. The word will be out. Oh, LeDun's goddamn LeDun's doing these things, But like, for CLABSI, who caused it? You ever seen anesthesiologists take credit for a CLABSI? And you never will, right? And then like treatment. Suppose somebody gets a CLABSI, there's a technical treatment for it. You can observe the pneumothorax, or you can do this.
The 50 got to space. Mid-axillary line, anterior axillary line. Okay. Up underrated. Look at mine.
Ready. Tom Petrie, Wolf on his PA.
Didn't tuck it.
Dad.
These guys that are scared of pneumothorax, I say to them, do you know how to put in a chest tube? And they go, yeah. No. Mommy, there's a monster under my bed, But CLABSI's a whole nother kettle of fish, right? All right, so basically I've been describing. I showed you how not to do an internal jugular vein, right? We, together, have established that you want it low in the neck and rotate it down. I come from the side of the bed for a number of reasons. And it's the only way I teach it. And I'd like you to consider adopting it, maybe do it on a mannequin a little bit first if you don't do that. But this is,
we're going to puncture the vein as low down above the clavicle as we can.
micropuncture equipment. It will make you better. Micropuncture equipment for your dialysis line.
Now the wire. Now we'll see that we're nice and low in the neck. We're not the middle. We're going to put the 5 French. I'm
going to keep coming. Keep coming out here. This wire.
We're not going to cut the skin. The skin is the barrier to protection. This feels like it's going to move.
I'm low in the neck.
The wire. Put a finger over the hole. On the set.
Side of the bed. Recommendation, not mandatory. Recommendation.
Now we're going to dilate the center French dilators. Okay, it's going to feel a little bit of pushing now. Okay, so okay, they have that. And put in the set French triple limit catheter. Going smoothly. I'm going to put this at about 19 to 20 steps because the nurse, where would you rather care for this catheter, the neck or at the chest? Yes.
One enlightened nurse. Low in the neck, rotate it down. Recommendation come from the side of the bed, right? But in contradistinction to the internal jugular vein, the ultrasound-guided axillary vein, what the doctors call subclavian, is standardized at the highest level. Every axillary vein will look like this or have the potential to look like this. It's standardized by where it's placed, by the geography of where it goes in. This is, you can muck it up, don't get me wrong, but the exit site is in the right place just by the nature of the deltoid pectoral groove and where you're going. Please, okay. This is the Shea Compendium 2022, update from 2014. One of the things they make a point, do not use PICS as a strategy to reduce collapsing. And I don't really understand why. Certainly, if you've got an ugly IJ, I would put in a PIC. But if you had a nice, perfect IJ, I would not put in a PIC, that kind of a thing, right? So basically, this paper said that the subclavian vein is the preferable site for central lines in ICU to reduce infections. Previously, in the 2014 compendium, they said the primary recommendation was to use the subclavian, but in order to avoid the femoral. That was changed to a positively formulated recommendation regarding the subclavian vein. In other words, if you're trying to prevent infection, this is where the line goes. Okay? When you use ultrasound, it's the axillary vein. What does the CDC say about this? 75-page guideline on Article 3 on page 11 and page 27 says use a subclavian site rather than a jugular or femoral. Article 7 says use ultrasound guidance. To the people in this room, that's interesting. Not really, it's interesting. All right. When you say subclavian and ultrasound, you're talking about the axillary vein because you can't see the infraclavicular subclavian vein with ultrasound, much less stick it, okay? But you can see the axillary vein all day long. This is what I'm talking about. So basically, the subclavian vein lives in the bony tunnel bordered by the first rib above and the clavicle above and the first rib below. So you got to stick your needle into that bony tunnel, right? Many things we disagree about. We agree about this. The optimal location for the dressing is on the chest. The chest has much less motion. You get a flat surface, all that stuff. And this is what it looks like, right? 5 procedures. We've discussed 2 of them. I'm going to show you now how we do the axillary vein. The axillary vein lives in the deltopectoral groove on the anterior chest wall, right? So I asked earlier what was your go-to vein, and it came out internal jugular. My go-to vein, all comers, and we'll get it, is the axillary vein. When I'm in the intensive care unit, I want to do the ultrasound-guided axillary vein. So we're going to be puncturing our axillary vein inside of the humeral head in the deltopectoral groove. Who is that? I'll tell you to be quiet, okay? Spit that skin bill on the way out. That sting, man? Why? Why you listening? Get it, Tina. There's my needle puncturing the axillary vein. The arteries to the left, the pleura is below. You have good flow? Micropuncture equipment that we push down on. Get no skin incision. You want less bleeding? Don't cut the skin. It's amazing how that works. You're spreading the catheter over the wire. Okay, the back side. All right. So, okay, there's our blue bullseye. You can see we're right in the deltopectoral group, right where we marked it. And there's, we're doing a medical procedure here. But when you put your... All right, so to put on the security device, I had a slabber. Put this on. Just a hard up. All right, good. So here we have an ultrasound-guided right axillary puncture. The dressing's in the right place. Turn your head to the side. We're giving it to the nurse in proper position where she can provide proper care and maintenance. We did not incise the skin. We did not suture it down. And the pump is not all the way into the skin. All right, so basically, based on these papers, the Shea Compendium, Timsit, and the Society of French Intensivists, and their underlying studies, my considered opinion is that the ultrasound-guided axillary vein is the location of choice for infection prevention considerations, absent CKD, right? I want you to ask your doctors why we're not doing, see what they say. Like I'm telling you, I have an evidentiary basis for what I'm doing. You can find an evidentiary basis for what you're doing. No problem, no question. But ask them why we're not doing. Don't even go into the axillary versus subclavian. Forget that. But ask them why they're not doing this, and see if if that reason rings like the stuff I'm saying probably is ringing true. A lot of it, I'm showing videos. I got my slides, my Brooklyn accent and stuff. But ask the guys why they're not doing this and see what they say. All right. Vascular access experts in Arizona, a famous group, whether you know it or not. What is a good reason to use the internal jugular vein? In fact, the reason.
I think.
Yes, Tiger, thank you. If the patient has chronic kidney disease, we're supposed to use the internal jugular vein to protect the real estate for grafts and fistulas, right? What is a bad reason to use the internal jugular vein? If you put a percutaneous jugular vein in here, go ahead, make your case to me. Make your case, okay? So basically, anybody ever see a patient with chronic kidney disease at a tracheostomy? It happens, right? So chronic kidney disease, Tiger says to use the internal jugular vein, right? Jack Dunn says for trach patients, don't use the internal jugular vein. So what's the solution? What's the solution to this? You're not supposed to use the axillary vein for the grafts and fistula on these patients. Have I done? Mid-thigh is a solution, or you can puncture the jugular vein and tunnel it out. Now, are you guys doing tunnel? Anybody doing tunnel? Okay. Now, RNs in this country are tunneling catheters, even dialysis catheters at the bedside. They're specially trained, but it can be done, right? For tunneling, I use a long 14-gauge angio catheter. BD makes a 14-gauge, 5.25-inch angio catheter. I don't know what you would use this thing for, besides making the subcutaneous tunnel. Then I have to cut off the hub to pull it through. So we're going to show that, right? I mean, this is the next step. I think you should be. And the tunnel is not the skill part of this procedure. The skill part is puncturing the vein and getting the tip in the right spot, like always, right? Okay. So I want you to pay attention. I'm going to nick the skin because I'm making a tunnel. I'm going to use dressing adhesive. I'm going to use the subcutaneous securement device, clexidine sponge dressing. The dressing is going to lay flat. This is bedside tunneling procedure. This should be the next thing. Boom. Hit it. Knowing that it's a hot button issue. But Keegan and Amy, make it happen here. Like pick the right pilot, Spot, Banner, Layla. We're doing tunneling now. You're telling, like, this is the tunnel. That 14-gauge angio cap, subcutaneous, you got to go over the clavity, come out here, sit. That after going, it's like hot. Let me show you once. Let me show you how to make the tunnel once. Then you brace. The rest of it's a pick or low IJ insertion.
Fractally.
Layla, pick the person that we're going to train for tunneling. Pick,
You move the peel. It's like the catheter, the peel away. We'll be at the end deeper. So this is telling us for the exact right spot at the K08 junction. So I felt it go in. Now I'm going to release and deploy. Like this, and we're going to put the top on. Okay. Let's go on this side, let's do this side. And the last thing we have to, the dressing is going to go.
The stuff from the bark of the tree, the gum mastic that drips down. You let it dry for about 30 seconds.
You have to lift that to dry for 30 seconds. You go away, Sheila. Listen. Feel the way it goes down. Sticks down very nice. dressing. But this is what I consider to be modern vascular access.
The date on there was 214. Doesn't look like it'll stay on for 7 days. It's the goal, standardizing practice at the highest level. That's what it looks like, right? All right, so 16 recommendations. We get into 9 and 10 a little bit. Sutural securement. All right. The 2024 standards of practice, right? Avoid the use of sutures. They're not an effective alternative to an engineered securement device, right? Sutures associated with needle stick, they break, biofilm, increase risk of infection, right? The CDC uses sutural securement device. I mean, it's been in the literature for quite a while, right? We were talking, you guys know the concept of pistoning? Yeah, everybody knows pistoning, right? So this is a friend of mine from Slovenia, Romana Jokic, right? And she was changing and dressing. She's an expert.
He's the night to go. We get to go. Night.
Even an expert changing the dressing with those adhesive things is going to have the catheter wiggling in and out. All right. So Marcy, using the gum mastic. What about Marcy? The studies that are out there show it decreases Marcy. It has essentially no Marcy in it, right? And this is what Marcy looks like. Anybody recognize that adhesive? That adhesive securement device? The skin came off when we,
Jeez.
Stop. You can do that,
You get this.
And we want to use, listen, for my family, please use an adhesive remover. Okay, please.
Underneath the dressings, you break the adhesive bonds and it comes out relatively easy.
No, it's good nice.
Good. As you get out, somebody. The applicant get that will relieve right underneath the dressing, and it's good way to get the solvent in the right location. Good.
Day 7 looks pretty good. All right. I get to visit a lot of, not as many as Keegan or Amy, but I get to visit a lot of hospitals and I find common things. The big one is nobody's in charge of vascular access. That leads to a lot of things like then following on that, these places will have one line, that 120 centimeter triple lumen catheter, okay? And another thing that I will tell you, Layla, I'm going to tell you which line in this hospital has the worst infection rates. It's the acute hemodialysis cath. In every hospital I go to, the acute HD catheters have the worst CLABSI rate, right? So I was lecturing on this topic, and the chief of surgery interrupted me. Now, I don't like being interrupted, but I like interrupting people. But he was the chief of surgery, so you know what I mean. It's all good, right?
Yes. I was going to ask, why do you think the HD catheters have high this? A lot of people want to say it's because people put them in with all else better. It's just the access, the patient,
Look at that athletic.
There's a whole bunch of reasons for it. One of them is like this catheter here. This is lipstick on this can't be put in the way it's put in like this, and it's folded down so it doesn't wind up in your auditory canal. No dressing with this catheter is ever stayed intact. So it's almost like you're defeated by the equipment. They're heavy catheters, put them all the fact. The patient just
You got out of it.
What we discussed earlier, low in the neck, rotate it down. My recommendation is to come from the side of the bed, right? Fifth procedure. Look at the probe. Hit the center of the probe. I'm working with a resident. He's doing some. You look at the probe.
It's connected. pitch it.
He's got a beard, an endotracheal tube, a short neck. You think I want to cut the skin in? Zynar is 4. You think I want to cut the skin in this gun?
Saving that.
It has 2 dilators. This,
And then with 9R 3.9s. 4. Okay, now because it's been dilated once, you should be able to get this approach. You put a little traction on the wire. Oh, look back. Okay, that's on it. The teaching point is, a patient like this with a short neck, on a ventilator with an endotracheal tube, we do not want it dressing up near the mandible, the hairline, or the ear. We want it down in the chest. Nurse, where do you want the dressing this patient, on the neck or on the chest? Why? Huh? Because a wise better to provide proper care and maintenance? Do I put words in your mouth? So that is Dixie is going to just lab. I'm good chance to stay on for the 7 days. Good.
Sorry, you're okay, sir. It's almost doing it.
gum master.
Okay, you'll be dressing goes on. Very nice, very in sticky positions. I'm going to retract the lens. Good.
Is that what dialysis catheters look like in your institution?
Really?
Good. Great. That's what they're supposed to look like. All right. I'm going to summarize this thing. You've been great so far. Infection prevention is an organizing principle of vascular access. Like everything we do, better have infection prevention, behind it, right? The guidelines will tell you to do hand hygiene and maximal barrier precautions. The manufacturers will sell you antimicrobial catheters and antimicrobial dressings. They'll sell you special end caps. They'll even sell you antimicrobial caps for the special end caps. But on your list of infection prevention measures, where is insert the catheter properly and dress them properly? And there's a cost for this. It's nothing. Just got to learn how to do it. You don't buy anything. You just have to learn how to do what's right for the patient. Low in the neck, rotate it downward, right? Back to the life cycle. People are going to come to you all the time. People out there, you tell them you're having this problem, they'll have the answer in their bag. They're going to sell you the answer to your problem. So some of the new stuff is antimicrobial special dressings, end caps, CHG bathing. If my patient is in the intensive care unit and his line is hanging out of his neck like this, please don't bathe him with chlorhexidine and think that you're helping him. Please put the catheter in properly and dress it properly, right? And locking solution has my interest because it deals with the internal pathway. Most of the stuff I've been discussing is the external pathway. Now, whether you buy this stuff or not is up to you. Somebody's going to make a case. You're going to say, this is our problem. That's going to help you with it, right? As an example, I travel around the world. You know what infection prevention around the world is? Switching from one chlorhexidine-containing dressing to a different chlorhexidine-containing dressing. Maybe that'll help you, right? But whether you buy this stuff or not is up to you. But I say, did you do this, Sparks? Did you have a good reason to put in lines? Did you do that standardized pre-insertion bundle? And then did you put the catheter in properly? At that point, if you want to buy something, be my guest. And if you don't do the basics right, you get what you get. Suppose there was a study that showed the outcomes from this were the same as the outcomes from this one. Suppose that's what the study showed. Wouldn't you do it like this anyway? You don't really need the study. You know that the chief of surgery, the dialysis catheter? If you go to the head of the bed and you put one of those crummy dialysis catheters with the curved tips in, the dressing's not going to stay intact. In fact, never. I've never seen one intact, right? We've got to stop teaching procedures that have never worked. What kind of ridiculous idiocy is this? We're teaching people, trainees, to do procedures that they're going to do for the rest of their life in ways that have never worked. If you want improved outcomes, these are my recommendations. When I go to hospitals, well, what are you doing for your labs? Oh, we're trying to fix care and maintenance, buying this product, buying that product. You have to fix insertion first. Why? It happens first. There's no fixing a bad insertion by good nursing care and maintenance. That's not how the world works, right? These things are a unit. The exit site, the securement, the dressing, like they're a unit. Like we have to almost Care and maintenance is 99%. We have to hand the nurse a line that she can work with. If a dressing is disrupted, you have to you go ahead and change the dressing. While you're getting the stuff to change the dressing, ask why. If the answer is it wasn't inserted properly, that's what you have to attack.